Hey, good evening, everyone. I'm Ibrahim. I'm one of the fellows at Sinai. I appreciate the opportunity to speak here. I'll get started. We have a 35-year-old female with no past medical history, which is a little different for most of our patients. She works as a hairdresser, doesn't have any toxic habits, and is married with children. Her only medication at the time we saw her was oral contraceptive pills, and her history starts back in 2020. So at that time, she presented to an emergency room with lower extremity pain. They do an ultrasound, and she gets diagnosed with a DVT from the common femoral down to the distal pop. At the time, she has no skin changes, no edema, just a little pain in the leg. She's discharged on anticoagulation, but due to insurance issues, it takes about a month to a month and a half for her to actually fill the prescription. And within that month, a month and a half from the acute DVT, she develops worsening left leg edema. Moving on a little further to 2020, about 3 months after her initial diagnosis, she sees her PMD and has an ultrasound with resolution of the DVT, but continues to have leg pain, especially with ambulation and especially with standing for long periods of time, and the pain lasts for a very long time. She's managed pretty conservatively, given reassurance that there's no DVT there, does a little bit of compression therapy, and goes on for almost a year. And after a year, she ends up having hyperpigmentation, pain, swelling, and now ulceration of that leg. Between the time she saw us from November into March, she was tried on a conservative therapy, prolonged course of antibiotic therapy as well as other conservative therapies, again reassured that her ABIs are normal and she has no DVT. So finally, she's referred to vascular cardiology, where we see that she's CEAP class 6, and we finally do a venous duplex with reflux, or actual venous study. Just to very briefly go over, in the first picture, you see the GSV, or the superficial vein, draining into the common femoral, and then you see the SSV draining into the popliteal vein. So when we're doing these reflux studies, we're looking for reflux in the superficial veins, but for this case, at least more importantly, we're looking for reflux in the deep veins as well. So during our DVT study, we saw that she has partial compressibility of the common femoral vein, indicating the signs of an old DVT, but non-occlusive. And we also noticed that she has reflux in the GSV, reflux in the SSV and POP, and more importantly, reflux in the common femoral vein. So going down our treatment algorithm, we have a patient who has clinical and physical signs of chronic venous insufficiency. We've tried our conservative therapy, and for this patient, that's unsatisfactory because she has a non-healing wound. We go down our non-invasive testing, and then we see that she has reflux in the deep veins, which would lead us to a venography, and we also see that she has a non-acute obstruction, which would lead us down the route of venography. And during venography, what we're looking for is compression of that left common iliac vein, most commonly by the right common iliac artery. So let's get to our venogram. We initially start off with femoral vein access. You could see that the femoral vein as well as the iliac vein is extremely dilated, with dilated gonadal and vertebral tributaries. And in the picture of the IVC through the pigtail, you can actually see a dilated azygous vein as well. And on the picture of the IVC, you can see that the actual IVC is almost completely obliterated. So our options at this point to consider: obtain right femoral access, attempt to cross the CTO from both sides and repair; obtain IJ access and get better imaging from above, which I don't think is that bad of an idea; place the patient on Lovenox and return in 3 months; or obtain cross-sectional imaging. Obviously, the answer is always get more information, so we obtain cross-sectional imaging. If you ignore the elephant on the screen for just a minute and look at the common femoral artery on both sides at the level of the confluence of the IVC, you can see that it's completely obliterated. And moving a little further to the actual level of the IVC and the aorta, you can see again the IVC is completely compressed by this large mass. So I know we talked a lot about endovascular and open repairs. So for this patient, we chose an open repair. We sent her for myomectomy, and following surgery, we ended up placing her on Xarelto 2.5 milligrams daily. We thought that'd be sufficient, and she had a follow-up DVT scan with no DVT. Unfortunately, she followed up with us a month after this procedure was done, and her venous ulcer was getting worse. Her pain was still present, so we thought we'd do another CT venogram. And every now and then, Occam's razor does not hold true. But during the CT venogram, we see that her IVC is no longer completely compressed, but at the level of the confluence and the left iliac vein, we see compression by both the right and left common iliac arteries. So in a patient with compression from mass, we also found compression from May-Thurner syndrome. So this time we took her back to the lab with a better idea of what we would find. We ended up getting bilateral common femoral vein access, crossing the lesion from both sides, taking our initial venography, and then assessing both sides with IVUS. These are still frames from our IVUS images, and you can see that there's severe compression at the level of the common iliac arteries, both on the right and left iliac vein. And so we ended up choosing two 16 by 160 Abre stents, and we were sizing based on that 2/3 rule, and then ended up deploying them in a kissing fashion. We did do a post-balloon post-dilation, and then after our post-dilation, this is our venogram. And most importantly, we did IVUS of both sides after the stents were deployed. And you can see that we have a huge luminal grain with an area of 182 on the right and an area of 146 on the left. This is a brief summary slide involving the treatment strategies for iliac compression. I have a list of the stents that are available to us now with the patency rates based on their respective trials. In this case, we had ended up choosing the Abre stent, which is 85.7%. And I think some of the topics to talk about when talking about these cases is when do you extend into the IVC? Do you do bilateral stenting when there's compression on both sides with symptoms just on one? And how do you size and oversize your stents as to avoid migration? And I think those still require some answers. And this is our patient. She doesn't have an iPhone 14, so the picture quality is not as good as the original picture, but you can see that she is healing. That's all.